we're ready, sir.
All right. Good afternoon. We are now sitting as the Board of Health for Prince George's County. Today, we're receiving an update on the coronavirus COVID-19. Pleased that we are joined by Dr. George Askew, who's the Deputy Chief Administrative Officer for Health, Human Services, and Education, as well as our Board of Health consultants, Dr. Terrence Fulham and Dr. Yolanda Hancock. With that, we will turn it over now to Dr. Askew for an update. Before we start, want to say thank you to Dr. Askew as well as Dr. Carter, who is not able to join us today, for the hard work that you're doing on behalf of the administration as well as the other members of the administration. Your regular communications and updates to us as the council and to the members of the public are much appreciated given this pandemic. So with that, Dr. Askew, we'll turn to you now. Thank you.
Thank you, Mr. Chair, and I'm happy to report that Dr. Carter is available to join us today, and and he'll also be part of the presentation that we'll make to make sure that it's well-rounded and you get all the information. I'm going to try to sort of focus on the big picture of where we are, where we've been, and where we are, and Dr. Carter will be able to give you some of the more specifics on some of the numbers right up to the moment, so that we're all caught up. As a quick review, coronavirus 19 or COVID-19 is a new.
Can I all my colleagues, can you just mute? So I know we're hearing a little bit of background, and then. When Dr. Askew and Dr. Carter are finished, I apologize, Dr. Carter, I didn't see you at the bottom. Then if members have particular questions, there is a function on this that you can raise your hand, or you can physically raise your hand, and I'll make a notation as we go through this. So we'll have Dr. Askew, Dr. Carter, and then we'll have both Dr. Fulham and Dr. Hancock provide some context, and then we'll go to questions. Okay, thank you, Dr. Askew.
Great. And yes, I think it'll be very helpful actually to have Dr. Fulham and Dr. Hancock provide particularly context around community and what folks are saying. And we've been meeting with them on a regular basis as well to help inform the work that we're doing at the county executive level. So again, as I was saying, a quick review. I know many of you know this information now, but just in case folks don't, coronavirus is typically a seasonal virus that causes mild to moderate cold, like mild flu-like symptoms. This new strain, the new strain COVID-19, is a strain of coronavirus we had not seen until now, and that's why it presents such challenges for us. There's no vaccine. There's no pharmaceutical or drug treatment for it, so there's no special medicine that we have shown clearly to date to be effective against it. And really, our only medicine, and when I say that, I mean it figuratively, our only medicine against COVID-19 is social distancing, and I'll get back to that later because I want to focus on that. As you know, this started in China. Spread globally and making it a global pandemic, spread to the U.S., started on our West Coast and worked its way here. When we saw this as a county, I think in many respects much faster than was seen at the national level, we planned for when it would hit Prince George's County, and not if it would hit Prince George's County. And just like we planned when it would hit and not if, and get prepared for that, we are now planning for when, not if, it will get worse. Our hope is by planning when it gets worse, that we will have the great fortune that it would not get as bad as we're planning for, but we don't want to be caught behind the wave on this. I sort of, it's like carrying your umbrella. If you carry your umbrella, it's almost certain that it's not going to rain that day. So we're going to be ready just in case. some of the broader themes that I think have been important for us as a county and as a county leadership and the county executive. County executive has been very transparent in her public information that's being delivered, and very much sticking to the facts and giving the community the facts as they come, and again taking this very seriously from the start. And I think the transparency is important, and we will continue to serve in that way. You notice that the governor, as well as the county, have been taking actions that have progressively ratcheted up our social distancing, our ability to, in a sense, stay away from each other, because there are folks who are infected that we don't know that they're infected, and there are folks who are infected that we do know who we can isolate. The difficulty in this is that in times of tragedy, in times of emergency, in times of urgency, our tendency is to come together as a people. And this is one time when we actually have to support each other is by staying apart rather than supporting each other by coming together. And as a community, I think we are doing a good job of that. We could do better, but we're doing a good job. The most recent big event that's happened here was our opening up of FedEx, our FedEx field site. Dr. Carter will talk a little bit more about that. Again, I'm going to sort of give the broad picture as I see it. The broad picture, FedEx field and the screening center that's there serves two purposes. In my mind, the priority purpose is that it addresses issues of disparity and equity that we had that we were struggling with, making sure that all folks had access, no matter what your geography, no matter what your race, your insurance, your level of income, that you had access to the same care that anyone else has in the county. And I think by opening up this screening site, we're achieving that. And the second piece is that it's going to help to take some of the pressure off of our hospital system so that people can be evaluated in an area outside of a hospital. We don't overrun our hospitals with people who don't actually need to be seen in a hospital setting, or even may not be someone who needs to be tested, but does need to be evaluated, educated, and then sent on their way, so that they know when they should return, in case their symptoms appear or symptoms begin to get worse. And again, that's an important part of it. One of the things that's coming up next that you'd be interested in is we're meeting with our hospital systems tomorrow. I'll convening that meeting with our CAO, Major Riddick, and we'll be talking to the health system leaders. We've actually been meeting with the health system leaders even before this to talk about the way we collaborate in the county around health. And this particular meeting is going to focus on their needs when it comes to what's going to happen next with respect to coronavirus, and how we can be supportive as a county with resources that they might need, that we may be able to help develop for them or support them as they begin to ramp up. There's a few questions that have come up before our presentation today that I'm going to try to address just very briefly. And I think these are questions that, in the end, Dr. Hancock and Dr. Fulham, and certainly Dr. Carter may also have some input on. One of the things is, what are we seeing as being the biggest health concern regarding COVID-19 in the community? And one of the things that I've noticed is that there's been a focus for folks as a concern on getting tested. I think the messaging that we need to promote even stronger is that getting tested is not a medicine, and getting tested doesn't increase an individual's likelihood of any likelihood of their clinical outcome. In other words, getting tested doesn't help us decide treatment for any individual. Your treatment's going to be the same whether or not you were tested. It will allow us to know better how to help you prevent other folks in your family and in your community from getting infected. But the most important thing to do is, no matter what your status is, whether or not you tested positive for it, is to assume you're positive, assume that other folks in the community are positive, and practice social distancing social distancing as we recommend it. Another question has been, so how can the county help support healthcare professionals on the front lines of the pandemic? And I think the biggest thing is to take heed of the recommendations and the criteria that have been set out with respect to how do you assess whether or not you need to be seen by a health professional. First of all, calling a health professional before you show up anywhere. If you want to really help the folks on the front line, if you're sick, call your provider, call our hotline, which now is available for folks who don't have a primary care doctor or a medical home, before you show up on the front lines where you may not necessarily need to be and overwhelming the system. Let's see some of the thinking of some of the other. I'll turn, I guess, with that. There was one other question that I'll try to address a little bit before I turn it over to Dr. Carter, and that is, trying to think ahead. I really love this question because it's folks who are actually now thinking about when we recover from this, which I think is an important message to deliver, because we will get through this and we're going to emerge a stronger Prince George's County. But when we do emerge from this, what things will we need to have in place, as we enter into our new normal, after we flatten the curve, after we've gotten to the point with coronavirus where we feel we're in good shape. And I was trying to look at even a little bit more ahead. One of the things is we have to do a better job of stabilizing and improving our safety net. I think if we've learned one thing from this, is that we need to make greater investments in our safety net and our safety net providers. Something that we kind of knew before, but it's this kind of example of a pandemic that really brings it to life for us. Second, I think investments in basic health and human services supports. The things that make people most vulnerable to coronavirus, COVID-19, are underlying health conditions. Underlying health conditions are what puts you at the greatest risk. Investments in health and human services on the front end puts you with fewer and fewer people who have underlying health conditions that put them at greater risk for health problems, no matter what comes along in the future. And finally, thinking about what do we have in stockpile for these kinds of events, and how quickly do we access that stockpile? Because one of the issues that has come up repeatedly and it remains a problem is access to enough equipment on a regular basis to make sure that we're all equipped to do the job that we have to do, particularly those folks on the front line. And with that, I think I'll turn it over to Dr. Carter, who can give you some more of the specifics of some of the on-the-ground work that's been going on that I think folks will be interested in hearing about. And I'll say from a very personal standpoint, it's been an honor working with Dr. Carter as part of this, as part of addressing and responding to this pandemic. It's been a wonderful partnership, and I'm very proud of the work that he's done, and proud of our selection in conjunction with the County Council and the Governor's Office and making him the health officer of Prince George's County. Dr. Carter?
Thank you very much, Dr. Askew. Good afternoon, Dr. Carter. I also extend my thanks to you and all the work that you've been doing. Appreciate you joining us this afternoon as well.
Thank you. Thank you, Dr. Askew. I really appreciate those kind words. This is just a brief update, a little bit more specifics, but I do think that Dr. Askew really hit on the major points. So overall case summary is, as of yesterday, we have 294 confirmed cases. Today it's over 300. We've had 6 deaths to date, 19 residents known to be hospitalized at the current time. Most of the deaths have ranged from, all of the deaths range from people in their 30s to 70s. Our residents in their 50s comprise a fourth of our cases. Overall, 60% of our cases have been in the range of 30 to 59 years of age. Currently, with the FedEx field testing site update, the first day of the pilot test went very, very well. It was successful. We scheduled about 60 people. 67 people were screened. Of those 67, 60 were tested. This was by appointment only at our screening site. To get an appointment, residents had to call our COVID hotline that health department set up at the beginning of the incident. It's 301-883-6627. Calls were assessed over the phone to see if they met the current CDC testing criteria, and only people with symptoms got tested. If they are at high risk, and they are in high-risk categories, and here are the guidelines for clinicians from the CDC. Number one priority, hospitalized patients, healthcare facility workers with symptoms. Priority two are patients in long-term care facility with symptoms, patients 65 years of age or older with symptoms, patients with underlying conditions with symptoms, and first responders with symptoms. Category three are critical infrastructure workers with symptoms, individuals who do not meet any of the above categories with symptoms, health facility workers and first responders, individuals with mild symptoms in communities experiencing high numbers of COVID hospitalizations. And as resources allow, we test individuals in the community where we see there is a rapid spread. Whenever people get tested on site or not, whether people get tested on site or not, everyone will receive guidance on social distancing, managing a respiratory illness at home, as well as the other a host of other public health information and advice we produce throughout the incident. We're also connecting them to healthcare and healthcare providers as needed. The site serves really three purposes, and I think Dr. Askew went over them. But as he said, it does help us offload the emergency room, but it also helps those folks who don't have insurance, don't have a doctor, have a place to go if they need testing. Now, update on personal protective equipment. So far, we've distributed 36,000 N95 masks and basically distributed them to hospitals, nursing homes, assisted living facilities, dialysis units, home health agencies, and UACs. We're also working on a guide for municipalities, a general guide document. Right now, I'm working with the OEM director, Ronnie Gill, who's also here with me. We're working with the hospital systems and the CEOs because we understand that there is going to be a significant surge that's coming. We're sort of reflective of what's happening in New York and Illinois and other hotspots. We are a hotspot also, and so we know that that surge is coming, and we're working very diligently to be sure that our hospital systems are prepared for that. Now, with regard to critical needs, we have critical needs around staffing, which is personal protective equipment and other equipment. In addition to ER space, we're going to need to have space for convalescent care and multiple other things that we can discuss. But we're preparing for the worst. As I said, we're reflecting what's going to happen in this region is going to be similar to what's happening to New York. New York is the first, and we're looking to make sure we're prepared. Emergency Operations Center summary. Since the first week in March, the county's Emergency Operations Center has been activated. That means that the Health Department and the Office of Emergency Management have been working 12-hour shifts, 7 days a week to ensure that our efforts to keep our communities safe and healthy are coordinated and communicated swiftly. Due to this activation, Health Department leadership has defined roles within the incident command system personnel chart to make things happen during the emergency response. I'm the incident command leader, so I've shared that responsibility with Ronnie Gill. My team fills the roles of logistics, planning, finance, safety, public information, operations, and administration. A COVID information call center has been staffed with trained staff and Spanish translators since the EOC has been activated. That number, 301-883-6627, is to help residents to get connected to the information and resources. Yep, alone, the call center logged nearly 500 calls. In terms of public messaging update, communication efforts began in the first week of February. Our communications team began pushing out fact sheets about COVID-19, what it is, how it spreads, how to keep yourself healthy, etc. Part of the EOC activation, the Joint Information Center, or the JIC, within the EOC structure was also activated. The JIC is the JIC is led by the County Executive's Communication and Media Relationship Team and combines the effort of all the county's PIOs for public messaging. Every day, the public messaging operation is expanded and modified based on the science of the COVID-19 spread and the guidance from the CDC and the state. The messaging has been in the form of regular press briefing and media availability about the COVID protection guidance and how the disease is tracked. Each press conference now features the health department's own Dr. Axel Reyes, who provides messages for Spanish residents. Fact sheets and infographics that explain the latest COVID disease guidance and advice tips to stay safe and healthy, which includes social distancing, quarantining, COVID prevention, hygiene techniques, senior-focused care and advice, what to do if you're sick, stay at home, understanding how germs spread, informing residents about COVID-related government operations, explaining Governor Hogan's COVID-related executive orders and what it means to citizens. All of these messages have been translated into Spanish, have been posted on social media channels of all the county agencies as a collaborative effort to share information. We also been posted to the main county's website as well as the county's dedicated coronavirus website, which is health.mypgc.us/coronavirus. Working with our community stakeholders and partners as well as other county agencies, these messages have been directly delivered to vulnerable populations and communities as much as possible. Production of these materials continue daily. Upcoming ones include several on mental health, dialysis, diabetes, just to name a few. Radio and TV spots conveying these messages to the audiences that we need to hear them, and both in English and Spanish have been initiated. That concludes my update.
Thank you very much, Dr. Carter. Very thorough, as always. As part of that, let me turn first to Dr. Fulham for his comments, then to Dr. Hancock, and then we'll start to take questions from my colleagues as part of that. Good afternoon, Dr. Fulham. Good to see you.
Good afternoon, Chairman Turner. Just want to thank Dr. Askew and Dr. Carter for their comments and all that they've covered. Just to add a couple of things, I think what you'll hear over and over and over again is the importance of containing the virus and preventing its spread. And that's done through social distancing, staying home as much as possible. It doesn't mean you can't walk out into your yard or go for a walk, but you should do it alone. You shouldn't do it with other people. When you look at how the virus is spread, it's spread in droplets. So it occurs with cough and sneezing and talking. But if you're more than 6 feet away, then the likelihood that you'll be contaminated is very, very low. So that is probably one of the most important things. We think that the virus also gets transferred through contact. You can pick it up on your hands. It survives on surfaces for several hours. So washing your hands with soap and water for at least 20 seconds is very helpful. If you use a hand sanitizer, the percentage of alcohol content in the hand sanitizer should be 60%. And those are also good ways of preventing transfer of the virus. This is extremely important, and Dr. Askew underlined the fact that we don't have a treatment for it, we don't have a vaccine for it, and if you understand that 80% of those infected will have no or mild to moderate symptoms, and if you have very mild or no symptoms, you may even have a negative test. there's probably no reason to get tested if you're not symptomatic, because even if you have been contacted by the virus, you may not be positive, and this helps us because it keeps us from overrunning the system and going to hospitals or going to the testing sites. But on the other hand, because we can't detect some of our members of our community who may have been exposed to the virus, that just underscores the importance of the staying home directive and the social distancing. So even if you are around people who are not symptomatic, it does not mean that they're not carrying the virus. And so it's very, very important to maintain a social distancing. It's very important to wash your hands. It's very important to wipe down surfaces. You can go outside. Going outside and being alone is actually quite safe. There's no, the virus is not floating through the air, so you don't have to worry about picking up the virus in that regard. 15% of those who get infected will have moderate to severe symptoms, and those are the patients that need to be evaluated. The most constant or the most reliable symptoms are fever, muscle aches, sometimes some GI complaints. You may have some nausea, you may have some diarrhea, and then several days into the symptom complex, you may start having some shortness of breath. And if that occurs, then you should be evaluated and you should contact your doctor. So Dr. Askew again made the comment that if you start having symptoms, you should contact your doctor, give them a call. They will screen you on the phone, and then you should self-assess every day, take your temperature, keep a record of your symptoms, the type of symptoms that you're having, understanding that most patients will have mild to moderate symptoms, but some patients will develop moderate to severe. And if you do have moderate to severe symptoms, then you're probably going to need to be seen. So just, I'll say one more comment and then I'll finish. Dr. Askew was talking about some of the things for after COVID, once the virus does pass through. I think that we have been exposed to this distance learning with Zoom and some of the other things. And at the academic centers, we're recognizing some of the advantages of utilizing distance learning. So I really think that the way we teach, the way we provide services in the healthcare industry in general is going to change because of COVID-19. And that ends my report. Thank you so much.
Thank you very much, Dr. Fulham, for that. Let me turn now to Dr. Hancock for any additional comments.
Sure. I think that the first thing I have to do is thank both Drs. Askew and Carter for the phenomenal job they've done in leading us through this pandemic. I can imagine it's no easy task. In terms of comments, really one of the things I want to focus on is the death rate. We see in the media a lot of reporting out of the number of people who are dying from COVID-19. Here in the state of Maryland, the death rate or the percentage of people who die after having the infection is lower than the national average. The national average being around 3.4%. In Maryland, it's only 1%. So 99% of people who are infected with COVID-19 actually recover from and do not succumb from the virus. So I think it's important, as much as the media reports out some of the challenging statistics, it's also important to focus on some of the positives that are coming out of this, and the fact that almost everyone who has COVID-19 infection actually recovers from it. One of the other areas of focus, I think that both Dr. Askew and Dr. Carter do a good job of putting information out to sort of control some of the narrative that's pushed out in either social media or mainstream media. I think that that's an important role for each of us in leadership positions, is to make sure that we're trying to educate the public on information like whether or not there's actually a cure for COVID-19, which has been discussed previously that there isn't, despite what they may have been hearing either from our federal administration or through media. The other interesting piece of it is that we focus on the high-risk groups, those who are seniors, those who are dealing with immunocompromise, those with chronic medical conditions, inclusive of heart disease, diabetes. Obesity is actually a risk factor with COVID-19 infections. And then I consider another high-risk group us healthcare professionals, the more exposure you have to a COVID-19 infection, the higher the likelihood is that you will acquire the infection yourself. So it's important to understand that those are high-risk groups, but it's also important to communicate that everyone is at risk, including our youth. And I know as a professor at GW, some of my students thought that they were impervious to acquiring COVID-19. One of them found out that she was not, and becoming positive because she was out and about doing what Generation Z does. So it's important for our young people to understand that they are much at risk. The same thing with children. Luckily, we're not seeing COVID-19 impacting children, particularly in the 0 to 9 group, as much as we do, for instance, with influenza, or even with the common cold. Little ones have, on average, between 8 to 10 colds a year. That's one of the theories as to why children aren't as adversely affected by COVID-19 as adults are. We still don't know exactly why, but the blessing is that our children are not as severely affected. We know that, I believe there was a 2-week-old baby nationally that was the youngest baby that was infected with COVID-19. Here in Maryland, we did have one 1-month-old that was tested positive. Children's Hospital has done a phenomenal job of creating a standalone testing facility for their patients. So we're able, I've been able to refer some of my patients to get tested there when the Secretary of Health told me and the other doctors in Maryland that we could not test other than for the individuals who meet the 4 criteria for within the CDC. So those were my highlights. I want to try at least highlight some of the positives in the midst of this pandemic so that we can celebrate the fact that most people are recovering.
Thank you very much, Dr. Hancock. I appreciate that. Let me try to turn to my colleagues now. If you will either physically raise your hand if you have a question, or there's the remote application as well. So I did have a couple raised. Let me start first with Councilmember Taveras, followed by Councilmember Davis, Councilmember Harrison, then Councilmember Anderson Walker. And just unmute yourself. Okay.
Hi, thank you. Thank you for all the work you're doing. It's amazing all the work that's being done here in the county. And as somebody who's been personally touched by this, I can definitely attest that, you know, I'm happy and proud to live here in the state of Maryland, for us taking this aggressive approach in addressing this so much earlier than even in New York, in my opinion.
Danny, before you ask your question, just for my colleagues, if you direct your question to a particular person, then this way they can respond since they're all muted as well, so they know. Okay.
Yes. So right now, I would like to ask. All these questions are being directed to Dr. Askew and Dr. Carter. First is are we looking to see if we can provide Medicaid expansion to undocumented individuals for testing, eval, and treatment? The reality is that to treat this, the virus, it costs $70,000, and a lot of people do not have the insurance to treat this. And while they're waiving fees for testing, they're not necessarily looking to waive fees for treatment. That's the first question. Second what is the advice being given to individuals in large households, overcrowded households, and living in multi-family buildings and such? And finally, what information are we gathering from FedEx Field in terms of from the people who are coming, so that we know who we're reaching and if there are any gaps? Is there any data regarding who exactly is coming to FedEx Field? Those are my 3 questions. Thank you. And I'll go on mute.
Dr. Carter, Dr. Askew? Dr. Carter, go ahead.
Sure. Can you hear me?
Yeah, go ahead, Dr. Carter.
Okay. The Medicaid expansion question is a very good question, and I know we have been bringing that up with currently with our people who are working in that particular area. I will get back to you on that question. Because I've been asking that same question, and I will find out more about it. In terms of the FedEx Steel question, we've only had to date 67 people come through. So we honestly haven't had a lot of, we haven't done demographics on that. We haven't done the data collection, collected the data, but we haven't done the data analysis on it. Because yesterday, once we finished, we had a series of other things that occurred, and we haven't even had a chance to sit down and completely debrief after that, after we had our first day. But I will say, though, that once it gets going, we will have that data, and I think we'll be able to furnish your council with what the demographics look like and how that's moving forward.
Dr. Astor, do you have anything to add?
I was just going to add to the Medicaid expansion question. You know, we can push from our level and sort of say this is something that we need based on what we're seeing in terms of utilization. But this is also a big legislative question where we could use the help of our legislators to use their leverage to talk to the folks at the state so that they can talk to the feds, federal folks as well. So that's, you know, this one would definitely require a partnership of sort of the clinical side, the executive branch, and the legislative branch.
Dr. Askew, do we have the demographic information on, and I'm sure we do, on those who come through for the testing at FedEx? Will we be able to tell how many without insurance, how many Medicaid? Because that would be important information as we try to get the expansion.
Yeah, I'm going to defer to Dr. Carter on that, but I believe we are collecting that information as part of their sign up.
We are collecting that information. However, information we don't collect, we are not asking people about whether they're undocumented or not. We don't ask them personal information about their documentation status. So they can come to us and feel comfortable that we're not concerned with that particular issue. Now, it may be good to get that information, but we decided that wasn't something we were going to do.
We can use the insurance status as a surrogate, yes, for uninsured, underinsured.
Let's do the phone.
Yeah, Dr. Carter, I think if you have a phone close by or somebody's live streaming it close by, that might give you the feedback. So.
And I don't want to ignore the other question about what do you do about folks in overcrowded housing, and how, you know, that's a real challenge, and this gets at the sort of the equity issues. And so whatever solutions we come up with or that we develop for folks who have been exposed or who have COVID-19 and the recommendations that we're making, we have to make sure we take those things into account and look for ways to make sure that those folks aren't at a disadvantage. You know, if you live in crowded housing and we tell you, you live in the 3-generation household and we tell you that you have to isolate yourself in that household, it's just not possible. So we have to think of more creative solutions for families that are going to have that challenge.
Thank you very much. Let me turn now to Councilmember Davis for his question.
I think I'm muted. Am I unmuted?
Yep, we can hear you.
That happens every once in a lifetime. My question, let me just start by saying to all of our healthcare professionals, thank you for the yeoman's job that you've been doing, and thank you for preparing us to weather what is likely to be even more of a storm than we've already had. And thank you for the depth of knowledge. It's oftentimes, I say to people that we do what we can do, but we don't know everything we need to know. And without you, we won't know exactly what to do. So my real question is to start with Dr. Askew and Carter, but I'd also like to hear from Dr. Fulham and Dr. Hancock. You know, my concern is always the level of coordination. I heard someone speak about what we could do as legislators, state, local, and federal. But oftentimes in the healthcare industry, this spirit of competition doesn't turn into the spirit that I always speak about of co-opetition. But in a crisis like we're facing now, I think that spirit of co-opetition has to be prevalent, has to be what we essentially turn from a spirit to action. And so my concern is with all of the different healthcare entities that practice currently in the state, we have Luminous, Kaiser, Adventist, MedStar, who's coordinating formally or informally the system of care to deal with this crisis as we know it? Is there a formal mechanism? Is there an informal mechanism that needs to be formalized? Is this something at this point, in the face of this crisis, that we may need to turn into some type of entity that does not exist? I'm not sure of it, but I'd love to hear your opinions. And I'll say, regionally, we've been having this conversation at COG with regard to the same issue. And so I want to make sure that from the perspective of Prince George's County, if we have yet to formally create mechanisms, that we do.
Okay, I'll start up with an answer. We began setting the stage for that kind of cooperation back in January, I think, is when we had our first meeting. Before we knew COVID was around, we called the leadership of all of the hospital systems that do business in Prince George's County, MedStar, Luminous, doctors, Washington Adventist, Children's Hospital, and we actually had our next meeting scheduled for April. And it basically said, through the county executive's leadership and her ability to say, we're taking charge of the healthcare of the folks in Prince George's County, and we want you to be partners in that, and we want to make sure that we're all rowing in the same direction. It was a fantastic meeting. I should mention also that Amos was there, Joe White was there, who pulled me aside afterwards and said, I've been here for 30 years and I have not seen that kind of meeting happen and that kind of discussion and cooperation around the table with everybody looking to, as I said, row in the same direction towards some common goals. Recognizing that for me, there's a single bottom line. The bottom line is the health and wellness of a million people. For hospital systems, they have a double bottom line, many of them. The health and wellness of the people, but also the health and wellness of their business. And so, recognizing that we have to find the proper intersection so that we take care of people the best way we can. With that said, moving into a situation like that, like we're having right now, we had already set the stage for cooperation. So now moving into, as this moves along, we're able to, as I said, we just sent out the email invite to the same people that came to the January meeting to come to a meeting tomorrow, show up at a meeting tomorrow virtually to talk about needs, but again, in a sense of cooperation. And I know that there are other structures that Dr. Carter and Ronnie Gill, who I know is there with Dr. Carter, can probably speak to, that are working through the EOC and other mechanisms that are building this cooperative body around the health systems to serve us during the pandemic. So I'll turn it to either one of them if they have anything to add to that.
Yeah, I'll start, and I think Ronnie will then supplement it. So I know you well know that the county health department meets once a month with the state for public health emergency preparedness, and so it's actually an ongoing event for the local health departments to work with the state to understand what to do in case we have an emergency. We have within the health department a structure that helps us to understand how to best approach hospital systems in an emergency and when they have to surge up. The state communicates with us and through our Office of Emergency Preparedness to be sure that we meet all the criteria that needs to be met, even if the supplies are short, etc., of staffing, of having emergency facilities, when to call in the medical reserve corps, all of this in convalescent space. It's so many. There's a lot of different factions, and what happens is we work with those hospital systems not only in the county but in the region to be sure that there are shared resources, and that when it is a surge, that we know exactly who's on first, second, and third. And we actually have been in that process. As a matter of fact, we had a call this morning, and we have ongoing calls to be sure that is ongoing. So there is a structure. There are exercises that we do during the year so that we can be prepared for if an emergency like this should occur. So I'll let Ronnie talk a little bit more about that.
Just real briefly, one of the things that the doctor talked about was the.
Hey, Ronnie, just introduce yourself since we don't have you listed on the screen for those who don't know you.
I'm sorry, I'm Ronnie Gill, Director of Emergency Management for the county. One thing that the councilman and to the entire council, I'd like to let everyone know, while Dr. Carter and Dr. Askew are the medical experts, OEM and my office, we are the coordination experts. And Dr. Carter and I have been joined at the hip over the last month. His entire staff is working out of the Emergency Operations Center. We talk daily, numerous times. As he expressed earlier, we had 2 calls with our hospitals earlier today. We will have another one this afternoon and wrap up those calls tomorrow. And what we're doing is coordinating all the resources that they may need to make it through the event. Now, I'll be the first to say, we see what's going on across the country. I cannot guarantee you, with the limited amount of resources, that we will be able to meet all of those needs. But the one thing that has happened is with each one of these partners, they know that we're here to support them. They know we're communicating with them. They know we have a plan in place to get through this crisis. So that coordination that you spoke about, council member, is already and has been working. So through this event, Dr. Carter will live here. So we will get through this together with the OEM coordination as well as the health department.
Thank you very much, Mr. Gill. With that, let me turn now to Councilmember Harrison for his question, if you unmute.
Thank you, Mr. Chair. Can you hear me?
Yeah, gotcha.
Great. I just want to first and foremost thank Dr. Askew, Dr. Carter, Dr. Fulham, Dr. Hancock, and all the healthcare professionals that are working in the front lines to keep us safe, keep us protected, but also combat against COVID-19. And so I just want to say thank you for your service. Truly appreciative. I just have one question, and it's about testing. You know, how are the results from the testing from the patients at the testing stations being communicated back to the patient and to the provider? Is there a plan? Is there a policy in place that you're following? How is that handled, the communication back to the patient and the provider?
And this is Dr. Carter. This is handled just like a normal laboratory is handled. So if when a patient has a test done, it's ordered by a physician. Whether that test is positive or negative, the lab sends the result back to the doctor, and the doctor then tells the patient, and the lab I don't know whether they're doing this or not, but sometimes the lab will also send you their information from the lab, and then the doctor will contact that patient and tell them the results of that lab. What the health department, the results of that lab, if it's a COVID test, also goes to the state. And then the state, if it's a positive, they report it to our health department. And the health department from that point does an investigation. Actually, right now we're at the point where there's so many investigations, it's hard to keep up with. But that is the way it typically goes. And what they don't tell us is who's negative. So I know the state has been working on trying to get us batch information back to say, well, who was negative, because the health department at this point only knows who's positive. And a lot of people will ask us, well, who was negative? We don't know who was negative. We don't even know everybody who got a test. What we do know is who was positive, whether they're positive here or if they're residents somewhere else. Even in the country, if they're Prince George's County resident, ultimately state to state, back to local, we'll get the information. So the patients themselves,
really get their information in the normal way from that physician.
Okay, I appreciate you answering that question, Dr. Carter. Real fast, Dr. Fulham and Dr. Hancock, could you please have the opportunity to weigh in on Councilmember Davis's question, please?
Dr. Fulham, you want to start? I got to unmute Dr. Fulham.
Yeah. Can you repeat the question for me, please?
So the question was related to coordination with healthcare providers in this.
Thank you for allowing me to comment. I wanted to comment, but it had gone on, so I stayed quiet. Actually, not only is that going well, in my opinion, in Maryland, but it's going across the border into the district as well. Most of them will have what we call a command center team, where we created a team that heads up the surge and looking for making sure that we have the personnel and the supplies and everything that we need to take care of our COVID-19 patients when they come in. And then we've identified best practices. There are some who have gotten started sooner than others, and so we share those developments with each other so that everyone gets a chance to benefit. A perfect example, I had a conference call with the command center chief at Frederick Hospital, Dr. Sardarian, who's an anesthesiologist, and they had got started a little bit earlier, so he was telling us about their program. And when these kinds of things happen, healthcare professionals, we really come together and work well together. The whole competition goes away because we understand what's at stake. Our patients and providing services for our patients, maintaining our healthcare workers and resources, making sure that we stay healthy, because if we go down, it can create a critical need. I have communications with physicians in New York. I have communications with physicians in New Orleans, and we're certainly learning from their experiences as well. So this is something that brings healthcare professionals together and really makes a big difference, I think, in the long run.
Thank you, Dr. Fulham. Dr. Hancock, anything additional?
Sure, I'll keep it brief. I think that this is excellent. I commend you, Dr. Askew, for starting this even before the COVID-19 pandemic. My hope is that this continues well beyond the pandemic, certainly in being able to address a lot of the health issues in our county. The way that we're going to do that is through collaborative effort. And, I think it was Governor Hogan who said yesterday, even today, that each independent state is really going to be responsible for its own rescue, and the fact that we're creating such an excellent platform by which all of our healthcare leaders are working together is going to do just that.
Thank you, Dr. Hancock. Okay, let me move now to Councilmember Anderson Walker. She'll be followed by Councilmember Franklin, Ivy, Hawkins, and then Councilmember Taveras had one follow-up questions. And Councilmember Claros.
I just want to say thank you so much to Dr. Askew, Dr. Carter, Dr. Hancock, Dr. Fulham, to Ronnie Gibb, Major Riddick, and I got to say Jonathan Butler, because and everyone involved. I know over the last couple days I've been in contact with you all. My question is really focused on the community deaths and the potential for that increasing. The term community deaths relates to people who never get any medical care, they don't get tested, and they die at home. And my understanding is that we've had 3 such deaths in the area already. I'm very concerned about our homeless population that doesn't have a way of isolating themselves. Well, that's probably not a good term, but quarantining themselves because they don't have a consistent place. I know that in the conversations I've had, with Dr. Carter and Major Riddick, the concern has really been, is there maybe some motel space or other space that we can set aside for people to have temporary housing? We know that many of the hotels, motels aren't being utilized right now. I know there's a cost related to this, but I don't know if it's a greater cost if we have people not quarantined and spreading in the community. So I don't know who might want to address that. The second question I have really has to do with logistics of taking care of our people on the front line, our public servants, public safety workers, our physicians, anyone that's working in the medical field that's exposed. Do you feel there's something that we can do as county council members to help support, maybe even logistically, to have some funds go towards food to have delivered to them, so there's not the question of how are we going to get out and go eat. But I'm just open to whatever it is we can do to support. We'd like to be able to have that conversation and see what we can come together to support you on. And that question's for anybody who cares to.
Sure. I'll jump in on the last question. We'll make sure to try to incorporate that question into what we ask the health systems tomorrow. They'll all be there, and we can ask them, are there things that we could do that we can bring back to council to support the frontline providers that we may not be thinking of. And that's part of the reason for bringing them together, because we don't know all of their needs. Do they need food? Do they need other things? Do they need, that they can't go home because they're working crazy shifts and they just want to spend 12 hours in a hotel, and again, I'm just making these things up, but these may be things that they may report back to us, and we'll get back to you. On the first thing about the among the 6 deaths that we've sadly had in the community, I'm gonna go back and make sure that we confirm where those deaths were happening. To my understanding, I know of one that happened within a home, and it brought up something that I was going to bring up earlier, and I was going to ask Doctors Fulham and Hancock about, is I'm hearing reports of the people who are ending up sickest in the hospital are those folks who may actually have someone in their household, or may even have a family friend who said, you don't look so great, you should go to the doctor. And folks who are responding, no, I'm okay, this is going to be all right. And not understanding how quickly this can evolve into something very, very serious. And once you start having particularly breathing issues, the folks who go 12, 24 hours with having shortness of breath or tightness in their chest and ignore it, are folks who are more likely to end up dying outside of the hospital because they're not getting in to seek care. And again, this is very anecdotal, so I'd love to hear what folks in the community are saying to confirm or disconfirm that that's the reality.
So a couple of things. We have received food from some of the local restaurants here in Howard, which you can imagine the surprise and the appreciative, just how wonderful that was. So we've experienced that. We've also had some gifts of masks and some other PPE equipment. I think those are the biggest resources. What scares us most is running out of ventilators. But obviously that's a huge problem, and it's not like we can snap our fingers and build a ventilator over the weekend or something like that. But that's probably that's what we look for, and we're concerned about when we have our command center meetings. We're always talking about how many ventilators we have, how many people are on ventilators, who's coming off, how many are COVID-19s, and how many are not. So that's really important, and certainly the social consciousness of our community is very, very important.
Thank you, Dr. Fulham. Dr. Hancock, anything?
Sure. So as a mom, I would say childcare has been, I'm blessed to have my mother here. I don't know what I'd do if she wasn't, but for a lot of parents who have children at home and they're working 12, 16, sometimes 36-hour shifts, and we don't have, as things are closing, people are afraid, particularly for healthcare providers. Some of us have been refused childcare because the daycare providers and other entities are afraid that because we're on the front lines, our children are at risk, that then puts them at risk. So that's something that's a real concern that I have seen, not just here in Maryland, but across the country. That's a huge concern in figuring out, I don't even know how assistance can be provided in that capacity. I think the very important issue that Dr. Askew brought up in terms, and Councilman Anderson Walker brought up in terms of people dying at home, community death, it goes back to testing. I think when you tell someone to just stay at home and self-isolate and not test them to let them know, okay, you have COVID-19, so you need to be at higher alert, people downplay their symptoms. I had a patient who was refused testing, and she's a nurse. She works in an ICU where COVID-19 patients are being taken care of, but because she was not in direct contact with her patients having COVID-19, she was refused the test and tested positive. 13-year-old who went to a school out here, a private school in Prince George's County. Teachers were tested positive. The families weren't made aware of which teachers were positive. He also tested positive. So if I followed the CDC's guidelines, neither one of them would have been tested. So these are the same, and these are people, mom, luckily the 12-year-old's mom had heightened awareness, and so she pushed, and I tested the child, and he came up positive. The nurse asked her hospital, and this wasn't here in Prince George's County, she lives in the county, but she works in Anne Arundel County. She was refused. And so when we say that they don't necessarily need to be tested, part of that challenge in not testing patients is that it downplays their risk. They say, okay, the doctor doesn't think I need to be tested, this is likely just a cold. And if 80% of people are either asymptomatic or mildly symptomatic, but we know that in the blink of an eye, symptoms can progress within 24 to 36 hours, especially for people who don't immediately have access to care. You have to balance between the $10,000 cost of an emergency room visit for something that someone didn't think was worthy enough to be tested for, then it becomes a little bit more difficult for us to be able to communicate to people, take your symptoms seriously, when they will then, I've had people come back at me and say, well, if you want me to take my symptoms seriously, then why don't you test me? And I think that's part of the messaging needs to be why we're not testing people. Is it that it's only those individuals who should be tested? Is it because testing supplies are limited and we have to be protective of those supplies because the ones who are most at risk, we need to know whether or not they're positive because that dictates treatment? Like, all of that language needs to be clear so that when you go back home and you sit in your living room and you start to develop shortness of breath, you take it more seriously than you would have if you don't have the capacity to be tested.
Thank you, Dr.
I think that message is spot on in terms of going back to what I was talking about earlier with respect to people that focused on testing and as testing in a sense as a treatment. If I'm that sick, I need to get tested and something different is going to happen. When really the message is follow your symptoms. That's going to be the key to your health and survival in this. If you're getting sick, that's when you need to move to do something and move to do something early on. If it's not just testing, it's still continuing to watch and checking in with your doctor every few hours or every day even. But we have to do a better job of getting that message out, and having a session like this is actually helpful. With regard to childcare, they have shut down all childcare centers in the state of Maryland, except for specialized childcare opportunities for folks who are frontline providers, including nurses, doctors, other first responders, and you can find that childcare going through Locate, LOCATE, at the state Department of
Education.
MSDE, the State Department of Education.
So Chair, can I just respond to that really quickly?
Dr. Hancock, let me move on because we got a lot of questions and we still have other business as well.
No worries.
We could stay, we could stay all afternoon and talk about that, but let me get through some of the questions because it might come up again. So let me move to Councilmember Franklin, followed by Councilmember Hyde.
Thank you, Mr. Chair, and thank you, everyone. I want to especially thank Dr. Carter, Dr. Askew, our entire administration leadership, all our healthcare frontline workers, first responders, law enforcement. Everyone is working together, and we truly, truly appreciate. We also, I think, appreciate the risk that our frontline healthcare workers and first responders are dealing with, just in terms of the COVID-19 and Before I go to my core question, let me ask briefly about that. Do we have special testing for frontline healthcare workers and first responders here in the county? Are they getting sort of priority to get tested?
This is Dr. Carter. They are in the, I thought I read the guidelines. They are in the guidelines of people who are priority to get tested if they have come in contact with a COVID positive person and show signs and symptoms. They are in the priority testing.
Gotcha. Okay.
Let me add one more. I actually had an exposure 2 weeks ago. That I got exposed to ended up developing symptoms 3 days later and became positive. I was asymptomatic but was able to get tested. The reason I got tested is so that I didn't have to be out of work for 14 days. We try to keep our healthcare professionals back to work. So I got tested that Thursday. The results came back on Sunday, and I was back to work on Monday. So I did miss 5 days, but I didn't have to miss 14. So we did get that test. So we had that opportunity.
Good to hear. So my main question is about contact tracing. Just in looking at I guess now just over 300 cases here in the county, I know we're investigating. What is that telling us about the sort of the way the spread is happening here in the county in terms of the contact tracing? What does that tell us in terms of how people are getting sick or how they're getting infected, I should say, and how they're spreading it? Are we learning anything from that sort of contact tracing that's being done?
I can tell you that what it tells us is that the virus is spreading rapidly, that the test really helps us understand about the spread, but remember, everybody can't, really the test is skewed toward people who had a doctor and could get a test. The people who didn't have a doctor who couldn't get a test, couldn't get the test, can't get the test in the same proportion. And the other thing about the testing is that it's late in the game because the virus has been spreading rapidly. So just like as you see, if you're looking to see what's happening in New York and the other places in the country, that's happening to us now. It's like a wave. So what our contact investigations tell us is that it's consistent with the science. It's when somebody comes in contact with somebody who is actively COVID, they can either acquire it, they can get the virus and have mild symptoms, or they cannot get the virus at all. But it turns out that for every one person, 2 to 3 people that they come, for every one of how can I say this? For every one positive, I'm sorry, I have my team here to make sure I can talk. For every one positive, there's 2 to 3 people who will acquire from that one positive. And that's the sort of the rate of spread. It's consistent. And so what we're seeing now in our county, that it's really spreading rapidly.
And right now, I think we're at 341. Is that right?
No, we may be 341 as we're talking, but the last time I checked, it was 294 plus. So you've got better information than me.
No, I was just looking at the state website. Yeah, okay. So
it may be because, as I said, it's last week this time I was talking about it was in the 50s. Now it's going up really rapidly. We could have had 100 today.
Wow.
So I'm just saying that it's possible because one day we had 80. So I mean, I don't want you to tell you the truth of what's happening. This is a rapid spread, and if you come in contact with somebody with COVID, they infect about 2 to 3 people. So it's spreading rapidly.
And do we have any sense about when our peak is going to happen here in the county? Is there a way to say that, or are we sort of indistinguishable from the state in that regard?
We can't say. We're indistinguishable. It's hard to say what our peak is because, number one, we don't have enough information to model it. But if New York is an indication, we're lagging behind them. So I keep an eye on New York because when they peak, we should be close behind them if we do all of the right things. And I think our state and our county are doing the right thing to squash this spread. So I'm optimistic
And do we have enough tests in the county? Do we have enough available tests that we need, or are we short? Well, but let me ask you, are we short on testing and are we short on ventilators and hospitals?
We're short on testing and we're short on ventilators, yes. Yeah, we don't have enough tests, but there's not enough tests nationally. The state doesn't have enough tests. We don't have enough tests.
And ventilators, are we short on ventilators?
We're not. So this is what's happening with ventilators. Right now, the ventilator situation is fine, but if we surge up, which we know we are, like New York surged up, then we won't have enough ventilators. So everybody is working very hard because we know it's coming. We're trying to get to the point where we have enough ventilators, but from what I understand, there's just not enough ventilators in the country. So we're working very hard to make sure. I'm hoping at the federal level, state is working very hard so that when we get in the eye of the storm, we have enough ventilators.
And our hospital bed capacity, like with the hospitals in the county, how is it?
The same is true with the hospital bed capacity. Right now, we're okay, but when we start to surge up, we're not okay. So we're working to make sure we get to the okay spot. The scenario that the state has developed has a worst case scenario and a best case scenario. We're looking at the worst case scenario and planning for that. So it means that hospitals in the area are going to need more, not less. And we're working on that.
Got it. Thank you, Mr. Franklin. Appreciate that. Let me turn now to
Thank you so much, Mr. Chair.
Go ahead.
Thank you, Mr. Chair. Thanks to all of you who've spoken today and people who aren't here. I know that Dr. Wright has been extremely involved, from the hospital, from University of Maryland, Capital Region Health, Prince George's Hospital, as most of us know it. And I know how tough it is over there and how anxious everybody is about the future. One question I had was about data. I did get partial answers in that it seems like maybe the state needs to be the one leading with collecting the data if we're not getting it back in the county. And if enough people, we don't have enough tests to test everybody who wants or needs a test, then our data is going to be skewed anyway. But it would be good eventually to know, to make sure that we are looking at this whole thing through a lens of equity, so we can make sure that we know that LGBTQ, Latinos, homeless people, everybody is getting treated well. We already know that some of these populations, including African Americans, even in Prince George's County, not be getting the same treatment that white people might get. So I want to make sure that we have a way of gathering that data to make sure that people are treated well. And I know that Dr. Hancock, you mentioned the encouraging thing that we have a lower death rate at this moment, but I was wondering if a lot of that has got to do with the fact that we have not gotten overwhelmed yet. So in a week or two, as our hospitals are likely to start to fill up, and we don't have enough ventilators and beds and everything else, can we expect that death rate to climb?
So why don't we try to address the first question first about the data collection and dissemination for, groups. I know that something that saw a recent story about getting that information disaggregated. I know they do it by age and by gender, but they haven't been able to do it by race or other criteria. Do we know, Dr. Askew, Dr. Carter, if that is something that the state is able to do?
Well, the state, when you say collect the data, when a person gets tested, that test actually there's a lot of data generated around that test about that person there, but that's their personal health information, of course. But to the point that we don't have the data to do predictive modeling, we're sort of behind the curve on that, because we would have needed to have done testing a month ago, and significant testing, in order to understand we could predict, it's all about predicting the spread and how long we should be socially isolated and how we're flattening the curve. That's what the test tells us. And we don't have enough data from tests right now to be able to say anything about that in a really scientific way. We can make educated guesses, just like Dr. Fauci does, and their modeling is getting better and better because the numbers are going up. But right now, we just don't have enough data to be able to do that type of modeling. What was the other question? I forgot. I was trying to write it down real quick.
That's okay. That first question still, though, is I think it would be possible, since each person does, whoever takes the test, there is data on that person. I don't need to know who that person is, but the data is there, and it seems that it's not coming back to the county. So that's why I thought the state might be the right place to gather it and kind of, give it crosstabs so we can know what's going on. But the other question had to do with our lower death rate at this moment, which is encouraging, but I'm trying to be practical about knowing what might be coming down the pike. And I know that Dr. Hancock had addressed that, so I just wanted her to expound a little bit of what might happen in a couple of weeks as we become more overwhelmed.
Sure. So as Dr. Askew mentioned earlier, we sort of trail behind New York. And when we look at New York's death rate, it's averaging at about 2.2%. California similarly is around 2.2%, still lower than what we have seen globally. The global death rate for COVID-19 is around 3.4%. It really is state-based. The great thing is that we're able to see what California and New York have done, learn from the missteps and the best practices that they've implemented, so that we don't hopefully and prayerfully have similar outcomes in terms of shortages of ventilators, physicians and other healthcare professionals running out of PPE, and a good number of healthcare workforce being impacted and unable to show up to serve in terms of patient care. When we look at states like Louisiana, where I'm from, the death rate in New Orleans right now is 4.5%, which is actually higher than the global average, and that speaks to the challenges with the healthcare system even before COVID-19 hit. I think because we have such excellent healthcare partners, Dr. Askew and Dr. Carter are doing a phenomenal job of getting them to work collectively together. I can't anticipate what the death rate will be, but given the fact that New York and California are still lower than what we're seeing globally, I still have hope that our death rate will be lower than a lot of our counterparts.
And just real quickly, if any of you could expound a little bit upon what is it that New York is doing that we're also doing that we're doing well?
Anyone want to take that question?
I will. I actually think I think what we're doing better because we did it earlier is social distancing. We have the benefit of not being as concentrated and as dense a place as New York City, for instance. So we have that bit of an advantage. But I will tell you that in conversations I had with colleagues, when our governor declared a state of emergency after 3 cases, the questions from New York that were given to me were, why did you declare a state of emergency after just 3 cases? So we knew that the governor was moving quickly, and the county executive was quite in favor of those moves, and it was bold. It was taking a chance. You got 3 cases and you're declaring a state of emergency in your state is a big deal, and that really gets you moving quickly towards bringing resources and also elevating the urgency of your current situation. And I think the measures that we've been taking since then, with respect to our ability to continue to look at social distancing and begin to now even more aggressively enforce it, is what's going to make the difference. If you look at some numbers, and we don't want to be too overly encouraged by these things because it's early, but if you look at the numbers coming back and sort of the doubling rates are starting to slow down quite significantly in places that have set strict social distancing rules. And so the hope is we're ahead of the curve in that respect. And when I say ahead of the curve, we're chasing this wave the whole time because as a nation we got a bit of a late start. But I think in terms of pushing social distancing, we're doing a good job, a really good job.
Dr. Fuller, did you have something?
I did, and I just want to underscore whatever you said, because I think this is really important. When you talk about the death rate, you're talking about the number of people who die divided by the number of people who have the disease. The problem is that we can't determine the denominator. And so now the good news is that likely the denominator is bigger, right? So even though we're seeing 3% and 2% death rates, the actual death rate may be lower. When you look at countries across the globe that have done, let's say, I hate to use the word best practices because everybody's taken a beating with this virus, but South Korea probably has done the best, and the only thing we can determine is that they tested hundreds of thousands of their population, and so they were able to get a little bit better data regarding their particular population. This is my personal view. I mean, this is not public data, but my personal opinion. But I will tell you that there is some things that we can get from historic controls, and what happened in New York and what happened in New Orleans and Detroit and some of the other places, most of the surges, particularly the really high ones, were related specifically to the fact that the social distancing wasn't a mainstay of the treatment or response to this virus. The density of New York and also with the party Mardi Gras in New Orleans and what happened immediately after Mardi Gras with regards to the surge. So I agree with Dr. Askew and Dr. Carter and Yolandra as we're looking at what's happening. We've been a little bit more aggressive about the social distancing. So and I just want to take the opportunity to just underline how important it is to maintain social distancing, to wash your hands. It's really the most effective treatment that we have to this virus.
Thank you, Dr. Fulham. Thank you, Councilmember Ivey. Let me turn now to Councilmember Hawkins, followed by Councilmember Claros, and then Councilmember Denoga when he returns. Let me just say this, colleagues, we're about 2:40. Hopefully we can finish this up in about 20 minutes because we do have another item that's as important as the information that we're getting today. So I just ask you if there are new questions as part of that, something that hasn't already been talked about. So with that, let me turn to Vice Chair Hawkins.
Thank you, Mr. Chair. I will make this very brief. I think I'll hold my questions.
All right, thank you, Mr. Hawkins. I'll try to figure it out since you're the one that's near the system as part of that. So let me turn now to Councilmember Claros. And Councilmember Hawkins, if you want to send me your question, I can answer it for you if we're not able to do it. Okay.
Thank you, Mr. Chair. And let me start by thanking once again Dr. Askew and Dr. Carter and your entire team and all the folks who've been working. It's been quite impressive to see the collaboration and the partnership happening across the county. And I also want to thank my colleagues for all their amazing questions. I do have a few that I don't think have been asked yet. One, just to go back to childcare for essential workers, I will just share that it looks like the state is in the midst, either in the last 24 hours or today and tomorrow, in approving a lot of other daycare centers for taking of essential workers for their kids. I only know that because I know Joe's Movement Emporium, which many of us council members are really well familiar with in Mount Rainier, has just been approved to provide childcare during the day for our essential workers. So I think a lot of that is starting to come online a little bit more now. I had a few questions. So one of them is, and in fact, just today, I was contacted by a resident who, like many of us, have been cleaning our house or our basement or our shed and realized that they have some additional masks from a previous project that they did. Now, granted, they're not brand new, but they might be newer than what some of our healthcare workers at some point may have the choice of using. Is there a way for residents to drop off supplies? Maybe they realize they don't need all that hand sanitizer they now have in their house, and it would be great if we could get that to our hospitals. Is there some place in Prince George's County where our residents could drop off supplies like that? Or if companies want to donate supplies that they might have or realize they have in storage that could help the effort, who would they contact?
Is Ronnie still there? Because I think that might be a good question for him.
I'm here. Can you hear me?
Yes.
Yep.
So, Councilwoman, for now, you can have me, email me, or would go to her, or if it's donations that would fit within the COVID parameters. We're in the midst of setting up a donation, a county donations email address. Until we get that set up, they can contact me directly.
Okay, so Director Gill, that was breaking up a little bit for me, but I think the summary is stay tuned for an email address for donations and a possible site for drop off. In the meantime, just send you an email directly if we're aware of any supplies out there. Does that sound about right?
That's correct. That's
great. Okay, good. The second question I have is, I know we've been working really hard to identify location, our Warm Nights program that houses our homeless, and many churches have been participating in that, is going to be stop operating this week. Have we identified a location to provide assistance for some of our most vulnerable residents, which are homeless here in Prince George's County?
I know we have been very aggressively searching out facilities, and so far we've been able to house folks in the current situation. I don't know if we're in the position of making an announcement on that as yet, but know that this is a problem that we will make sure is solved before we reach a deadline. The deadline for folks not having a place that will be taken care of. But and again, I don't know. This is again, like everything else, is evolving. So there could be an answer and an announcement to be made. But I would want to check with the folks who've been working on it just to make sure that I don't get out ahead of myself.
I appreciate that response. Dr. Askew, I know you all have been working on it really hard, and I think this is the last week or days for the Warm Night Shelter, so hopefully we'll hear the announcement pretty soon. But I appreciate that response. Second question, or third question, I guess. I think Dr. Carter mentioned convalescent care, and I think Dr. Askew, you spoke of the fact that some families have 3 generations in their home, a home that actually might be a fairly small home. And so the ability to self-isolate is practically impossible. And then you could be, in essence, spreading the virus to even more vulnerable people. So I'm just sort of curious where we are and in terms of figuring out possible locations for people to be able to quarantine themselves, for instance, away from their family, if we want to use that terminology, or convalescent care, which I think is the terminology that Dr. Carter used.
Well, this is Dr. Carter. When I was using convalescent care, I meant convalescent care for people who are coming out of the hospital but needed to be in convalescent care. That is what I was referring to, because I know the hospital systems are concerned about what happens when a person leaves the hospital. Is there enough space for them if they have to do, be able to, do we have enough people to care for them once they leave the hospital and they're vulnerable? So that's a different thing, but I understand what you're saying. And right now, we actually, in terms of isolating folks, we started with our first responders and our essential personnel, and then we're looking at our homeless. We haven't gotten down to the level of helping folks who are not in those high priorities yet. So I can't tell you that we are working on that as right now. So Dr. Askew may know more about that. But right now, what we're doing is in those priorities right now in terms of finding shelter and being able to isolate them.
Okay, so let me give you an example of sort of why and I'm sure this is on your list, but there's a lot on the list, but sort of why I think about this one is I was on a call with a friend of mine, actually in Westchester, New York, who's helping to look out for a woman who's now on her own, was just diagnosed with double pneumonia, still waiting for her test results related to COVID-19, although I think most of us will assume that if she has pneumonia in both of her lungs, the likelihood she is positive is fairly high. And those are the types of cases, if you had pneumonia in both of your lungs, 6 months ago, you would be hospitalized for that. Or 3 months ago, you would be hospitalized for that. That's no longer the protocol out of New York because her case is not bad enough yet. And so that's sort of an example of, I think we have a lot of people who are living on their own, or we have a lot of single moms who might be taking care of their kids at the same time, but could also be ones who are themselves unhealthy. And then we also have the situation where we have 3 generations in the same house and 1 bathroom being used, sending someone back home to try to self-isolate in that scenario with the symptoms they're showing is not going to help contain, in my humble opinion, the virus. So I'm just going to continue to push that I think we need to think about how to prepare for the surge and the fact that not everyone will be able to be in the hospital, and we will need other spaces for some people to be providing care. That makes some sense.
Oh, it makes sense. No, we're thinking about it. I agree. That makes a lot of sense. We're thinking about that. So it's in the mix. I just want you to know we are thinking about that, and I think that's an excellent point.
Okay. And then I have just a few more questions to close out. So going back to the FedEx site, I'm really excited to hear that 60 people were tested today of the 67 that were screened. Can you give us a sense of, one, what's the maximum that can be screened daily out of the FedEx site, or sort of the range maybe? 2, when someone calls our hotline number, 883-6627, if I got it correct, what would they be, who will be answering that phone? Is there a Spanish speaker available when that phone is being answered? So that's sort of questions around the FedEx site.
Yes, so starting with the last question first, yes, there is a Spanish speaker. When they call for an appointment, what we're trying to do with people is to make sure that they are in that category, to figure out whether or not they need to be screened, whether they're in the high priority category, which I read out earlier. But it's a telemedicine, it's a telehealth event, so that one of the things, the reason we're doing it that way is because there are people who may not qualify to get tested, but they may need to be referred to a doctor. So we're making sure they get referred to a doctor or followed up, because that's our biggest need is that we had people who didn't have a doctor. We want to be sure that we get people at least connected. This is sort of our first step, and we're working through that. The maximum number of tests we can do in a day at a site is 100. And that's what the state has limited us to, with 100 a day. That's not the maximum number of people we can see in a day, but that's the maximum number of tests we can do in a day. The maximum number of people we can do in a day is more than that, but it's not significantly more than that, given the number of people that we have working, basically staffing. But as we grow, this first week is when we're looking at how we can best expand. We're thinking about how we can make this a permanent way of helping our people who don't have doctors. And we're thinking, and we're putting those processes and thoughts in place. So to be continued, I will update you with this, but that's where we are with the FedEx site right now.
And thank you again, and thank you guys so much for your work behind the scenes. I know the county executive, Angela Alsobrooks, mentioned Dr. Carter. This was sort of your brainchild. I'm sure there was a team of people who, this was your brainchild, but I think
my whole team's brainchild. It's not Dr. Carter's brainchild. This is the whole team came together. Diane Young stepped up and took the lead. It's the whole team that did actually work through this and thinking about the pitfalls that might occur and the challenges. So I don't want to say it was my brainchild. I wanted to say it's the health department team's brainchild, and we're working very hard to make sure that we can do even more. We got a lot more to do, and it's a lot of effort, and we don't have a lot of staff, but they work very hard, and I'm optimistic that we'll get the best we can do out of that site, and as we expand it to make it sustainable.
Well, congrats to you and your team. I think it's just really great on our federally qualified health centers. And my last thing I'll just say is...
Danielle, we're going to have to move on, so if you could just, we have two more council colleagues who'd like to get some questions in.
I'm just closing out right now. So as Dr. Askew mentioned about the improvement of our safety net, I think most of my colleagues knew, as well as Dr. Carter and Dr. Askew, that I was going to go in this year on a very heavy push, because we do have to realign the funding we're providing to our health and human services and our departments. And I'm going to share with you that I think that is still the same, even though we will face really tough decisions coming up over the next months. We have to continue to invest in improving our safety net. And I look forward to working with my colleagues and Dr. Askew and Dr. Carter in doing so. So thank you.
Thank you, Daniel. Let me move now to Councilmember Denoga, who I think has a question actually for Mr. Gill. Bye.
Thank you. I want to express my appreciation to all the medical and emergency preparedness professionals that we have. My question relates to food distribution. I'll be really brief, and maybe this is a question that'll be answered offline. I'm getting a lot of questions about what resources are available. We had the capital area food banks making food available a week or so ago, and those pop-ups have not come back. Now, my understanding is that we're losing some of the traditional food banks because of lack of volunteers or lack of people donating food. We have the senior distribution that we've been doing for years. That hits almost 600 people, but we have more seniors who want to join. So the question I have is, has the county administration put together a list of food resources that we can distribute or at least have in our office so we know where to direct people? I know the Capital Area Food Bank has a nice interactive map. I've seen that, but are we aware of information that we can provide to people in our area where they can find food distribution that's still active? That's my question. Thank you.
No problem. Thank you, Councilman, for the question. What I will do is go back and speak with the social services, family services partners, get that list and put it together and get that to your office.
Oh, yeah, share that with everybody, please.
Yes, sir.
All right, thank you.
Thank you, Councilmember Denoga. So in the interest of time, because I know we might lose some people at 3 o'clock, let me do a speed round of questions, and we'll just have either Dr. Askew or Dr. Carter just respond to those real quick. There was a question about, I know University of Maryland Medical System is looking at the Laurel Regional Hospital for potential additional, along with this, as part of that process. Are there any other county facilities that we may be looking at if we need them, if we do have the surge? That's one. Second one, to what extent are we monitoring particularly our senior citizen locations, given some of the recent news about those issues in other parts of the state and the country? And then I think those two are good for now. So Dr. Carter, Dr. Askew.
Yeah, I'll answer the second question first. We've been very aggressive about reaching out to our senior citizen facilities and making sure that they have the most up-to-date information, things to look for. And so, yes, we are very close to our senior facilities and making sure that they have what they need. And the first question, I have not heard of any specific sites that are being moved on as aggressively as they are moving at Laurel. The plan there is for April 20th or thereabouts to have that as a facility up and running. And Joe Wright is working very hard to get that ready for the UMMS system.
All right, thank you. So why don't we do this in the last couple of minutes that we have, when we have you, Dr. Askew, Dr. Carter, your final comments, and then we'll go to Dr. Fulham and Dr. Hancock for any final comments, and then we'll conclude and move on with the rest of the council business at that point.
Sure, I'll just thank you for the opportunity to share information and to hear the questions. It really helps to drive our work and guide our work when we, particularly when it comes to issues of communication and making sure that we're getting out the right information. Want to emphasize, as I did at the beginning, social distancing is our only medicine here. It's our best medicine. It's a proven effective medicine, and the more we can reinforce, not just for ourselves, but with our neighbors and our friends, and it's hard to be apart. It doesn't seem like this is the best support, but the best support is to be apart right now. And I congratulate Prince George's residents for their ability to do social distancing, and in the end, it's going to make us again a better community.
Thank you, Dr. Askew. Dr. Carter.
I echo that, and I just wanted to thank you all for the support you all have given us. We really appreciate your support, even when you tell us about things in the community. It helps us to shape our thinking. We love your feedback. We need the feedback in order for us to be sure that we're meeting everybody's needs. And so that's all I really want to say. We're really grateful for the fact that we're in a county where we have such cooperation, and that's really satisfying to not only to me, I know to Dr. Askew, but our entire team.
Thank you very much, Dr. Carter. Dr. Fulham.
I believe he's up. Are you still here, Terry?
Dr. Hancock, I'm sorry, you had to jump off, I know.
Right. So I would just, again, I want to thank Dr. Askew and Dr. Carter for allowing me to assist in any way I could, and particularly in terms of communication to the community. Speaking of communication, I think it's important for the County Council to continue communicating to your constituents. For some individuals who do not have loved ones with them, social distancing can be a challenge because they're not able to leave their homes. There isn't anyone really checking in on them. So your newsletters and your continuous communication through social media may be the only way in which they're able to get credible information. So just continue to keep that information flowing.
All right. Thank you very much, Dr. Askew, Dr. Carter, Dr. Hancock, and Dr. Fulham, who had to jump off for your participating today in our Board of Health. It's our expectation that we will have more regular ones of these given the circumstances and to inform our residents as well as keep us up to date. We all the communications that you are having. That goes to Mr. Gill as well as the head of the emergency management operations, as well as County Executive also Brooks herself. If there are any additional questions that we have, we're trying to funnel them to you as best we can, so we're not overwhelming you, but the information that we need to obviously relay to our constituents as well. So with that, thank you again. You guys can all leave the meeting, go on about business as part of that. With that, let me just ask my colleagues if they'd unmute for a second. Is there a motion to adjourn the Board of Health?
So
all right, I have a motion by Mr. Davis. I believe that was Mr. Second. All those in favor say aye.
Aye.
Any opposed? Any abstentions? All the ayes have it. So stay with us. We're going to transition back and reconvene into our council session to undertake our second business for this council session. And I want to thank our economic development team for their patience as we went through the Board of Health. So, Ms. Brown, let us know when you're ready, okay?